Thank you, Dr. Jasjit. A very good morning to all of you. So, Dr. Nigam already told and made us understand that obesity is not just a cosmetic problem, but it's a disease, and we don't think about treating diabetes. We know that HbA1c is more than 6.5 or 7, so we need to start treatment. We know that blood pressure is also high, that person requires treatment. Similarly, we need to understand that obesity is also a disease which will require treatment, and it's not that everybody has to be started on medicine, but at least they should be started on a lifestyle change. And if that lifestyle change is not reaching target, it's time that we also consider starting a medicine. So these are the disclaimers. So it has been, this talk is through Lily, and these are my disclosures. And also now we'll move on to the molecule. And this now, till now, we have all been using GLP-1 analogs for management of diabetes, and sometimes we use it for obesity also. These are approved indications. And so GLP-1 we all know, so it has a central mechanism of action. So primarily it will act by reducing food intake. Dr. Nigam showed the satiety center. So all these hormones which uh, promote eating behavior, so they get suppressed. So it also causes, we all know that, uh, glucose dependent insulin secretion, and also the counter regulatory hormone glucagon, which has a role in hepatic gluconeogenesis, that also gets suppressed, and it additionally delays gastric emptying also. But the main challenge we get with this molecule, so we know that we have been using maybe the injectable form of injectable liraglutide. So we have been using, so it's approved in India and we have been using it. The oral semaglutide option is also available. So what we see with this problem is that there is a lot of nausea and anorexia which takes place. So there, most of the obesity indications are at even at a higher dose. But in our country, we really need to, what we also need to understand is that many of the people, when you try to increase, say, liraglutide from 1.2 to 1.8, or you are using semaglutide and oral semaglutide and trying to increase from 7 to 14, so many of these patients actually drop out, and they do not are not able to continue these molecules for a very long duration because of the GI side effects. So this concept of active targeting multiple receptors came in. So this is a huge branch of anti-obesity uh, drugs are there, where not only GLP-1, which has a proven safety in terms of diabetes control and obesity management, and also severe risk reduction. So we started understanding that if you are targeting multiple receptors, so like diabetes has, we started with two three molecules, now we are targeting multiple aspects of diabetes management. Similarly for obesity also, and also for partly for diabetes control also, if you are using multi-pronged approach, that works better. So if we look into the physiology of GIP activity, and we all know that tirzepatide is a combination which where both GLP and GIP-1 activity was there, is it will reduce food intake, and it has the unique advantage of decreasing nausea, which is uh, which is a major side effect with GLP-1 agonist. So what we have learned from the trials, and many of our colleagues have been part of the phase 3 trials, and which was partly done in many patients were recruited from India also. So the the nausea related side effect is actually slightly less as compared to a GLP-1 agonist. So that is one advantage. So it decreases nausea, so increases the tolerability, and it has some action on adipose tissue also, where it increases insulin sensitivity over there. It increases the lipid buffering capacity, increases adipose tissue blood flow, increases storage capacity, and finally, so what we know that there is this concept that the white adipose tissue acts as a buffer. And if by buffering, what it does is, so it's storing fat, and if the calorie intake is excessively more, this fat will spill over. And also during the spillover, there is an chronic inflammation, low grade, which sets in. So this low grade chronic inflammation and this fat deposition in organs like liver, pancreas, even epicardiac fat, they all have negative implications on our health outcomes. So, so this molecule, in addition to having the GLP-1 activity of which will be more or less similar, it has GIP-1 has an additional advantage of promoting lipogenesis. How it translates to weight loss and better diabetes control, partly maybe because of the chronic inflammation, but again, the suppression of the chronic inflammation which occurs in dysfunctional adipose tissue. But again, it's a subject of research which is ongoing. So, and it in from the pancreas, it increases insulin secretion, and it also has a contradictory effect. So GLP-1, we know that it suppresses glucagon, but this molecule is slightly different, that it actually increases the glucagon secretion. So this is a combination of a single molecule. It has both the native sequence is GIP-1, and it has both activities on both the receptors. So it has almost equivalent activity at the GIP receptor for compared to the native molecule, but the GLP-1 activity is actually 5 times lesser than the native GLP-1. So there is slightly difference in that, and the mean half-life is almost 5 days. So that gives you the advantage that you can dose every week. So the dosing is weekly, and no dose adjustment is recommended for patients with renal or hepatic impairment, because so there are studies to prove, so we don't need to adjust dose. So we'll now go into the clinical data and also the basic premises of this molecule. One is glycemic control. We'll go into the details of it. One is weight reduction. It has a positive impact on lipid metabolism, and also it has a positive effect on cardiorenal effects. So we have dedicated sessions later for the for the RCTs which were done for approval of this molecule and also studied. So Surmount and Surpass, we have dedicated talks for that. So I will just briefly give you an outline of the overall way it acts. So glycemic control. So this was a Surpass trial. So this were the series of trials which were done to understand how it works as a anti-diabetic agent or glucose lowering agent. So it has been compared to placebo, it has been compared to semaglutide, it has been compared to injection degludec, it has been compared to injection glargine. All these trials starting from Surpass 1 to Surpass 4 and Surpass 5, what we see is that even so you might think as of now that semaglutide is a molecule which has the strongest, so maybe apart from insulin, obviously we know that insulin acts in a different way, but as a glucose lowering agent, semaglutide in trials lowered HbA1c to the maximum extent. Even this molecule did better than better than semaglutide, with almost additional 2 to 3%, 2.3 to 2.4% of HbA1c reduction. So this is something which is quite promising. And this is again mostly related to the weight loss and overall improvement in metabolism. So as I told you, Surpass 2, it showed superiority, clinically significant superiority in comparison to semaglutide. Now, if we slightly look into the mechanistic aspect, we know the first phase as well as the second phase, insulin secretion goes down in diabetes. So both this, when we studied this molecule through hyperglycemic camp, so these were more a small group of patients, pathophysiological, understanding the pathophysiological mechanism of the molecule was important. Both the first phase insulin secretion as well as the second phase insulin secretion, it got better. So these are all promising data. And if you look, and we already showed that physiologically GIP actually increases glucagon, so you might think that the glycemic efficacy will go down. But again, so there are two factors playing here. GLP-1 is suppressing glucagon, GIP is increasing glucagon. So what we see is that if the glucagon the area under curve with glucagon response is similar, and but at the same time the glucagon response to induced hypoglycemia, which is the compensatory response, that is also similar. So we have both we have the safety mechanism in place also, and that graph we have not shown, but the glucagon area under curve overall is also similar. So the glucagon response is not going to come against glycemic control in this case. For the glycemic aspect, what we see is that it has one of the most robust glucose lowering efficacy. It improves beta cell function as well as insulin sensitivity. There is a reduction in glucagon overall, greater reduction in glucagon area under curve than semaglutide. In fact, it's better than semaglutide. So the effect of GIP does not hamper the glucagon response of tirzepatide. And also, as a precautionary measure, our body secretes glucagon to counteract hypoglycemia. That aspect is also stable in this case. So if you now look into the weight reduction data, so this is one of the most promising molecule in terms of weight reduction. In which there are some others which are still undergoing trial, but again, out of all the approved molecule for weight reduction, so it causes weight loss in the range of the 15 mg. One causes weight loss in the range of 22.5 compared to placebo. So again, all these participants were actually getting lifestyle. So this is lifestyle changes where there was almost a 500 kilocalorie deficit, plus they were doing 150 minutes of exercise. So that was a placebo arm. So compared to that, and the tirzepatide arm was doing the same, plus was getting tirzepatide. So you see that there is a difference of almost 22.5 compared to placebo. So this is almost, so in bariatric surgery we reach around 25-30% weight loss, and Dr. Nigam already told that if you can lose around 10% of weight, so there are multiple benefits in terms of glycemic response. So all these responses you are going to get. So that is something. So one of the most promising data in terms of weight loss we have from this molecule in large randomized multi-center trials, and India also is a participant to that. So whenever you lose weight, so the patient will actually come back and will tell you, I am getting thinner. My relatives are telling, my neighbors are telling, I'm not looking that good. And so sometimes you need to, again, obesity requires lots of whenever you are treating a person with obesity, you need to keep on communicating. So people will come with different challenges. So what you can tell your patient is that it's predominantly the fat mass which is going down, the lean mass is slightly decreased, but again, so the fat loss is the primary benefit, lean mass slightly decreased but not that much. And most importantly, the visceral adipose tissue, which is the marker of multiple and it promotes multiple complications, that is the one which is most significantly decreased compared to placebo, which goes down by almost 40%. So that is something which will help to prevent complications, and these are again very, very encouraging data. So this was a trial which was done to understand the effect on sleeping metabolic rate. So as Dr. Nigam told that if somebody is trying to lose weight, there are multiple compensatory changes in the body. You have a metabolic set point. So body tries to keep your weight at that level. So you really need to work quite hard to break that barrier and lose weight. So one of these problems is your metabolic rate as a compensation. Whenever you are losing weight, it slows down and promotes weight gain. So, and in the animal studies, it was seen that the sleeping metabolic rate in rodent models actually that actually had gone down, so that might have prevented for excess weight gain. But in human, what we see, these are studies again done to understand the sleeping metabolic rate in whole room indirect calorie by indirect calorimetry method. So it was seen that there was no difference in the metabolic rate. The metabolic rate for this molecule was preserved. So, and overall the energy expenditure, that is also preserved, so that there is no major difference in placebo between the two. So that is something again which was only seen in animal studies but not replicated in human trials. And so primary mechanism will still be decreasing the hedonic eating component. Again, there are types of eating, so some amount of eating which is physiological, but whenever you are getting eating for pleasure or satisfaction, so there is a component of hedonic eating which comes in. So it decreases the food craving for multiple types of food. So that has all been studied. High fat, sweets, carbohydrate or starches, fast foods, fats, fruits and vegetables. So all components of eating primarily which will give you pleasure, so that actually comes down. We'll now have a brief look at the lipid metabolism also. So these are, we all know that one of the major drivers of cardiovascular disease will be dyslipidemia, and Indians or most of the Indians are having dyslipidemia. They will have this characteristic pattern of slightly high LDL, triglyceride is also high, HDL is low, and LDL are dense. So all these components can again actually improve with use of tirzepatide. So again, that has been convincingly proved. So LDL comes down, total cholesterol comes down, and the HDL, which is the good cholesterol, that actually goes up. So there are cardiorenal benefits also. We have, with the dedicated trials are expected for CV outcome are expected in this year. And so one of the problem with GLP-1 analogs is that the pulse rate slightly goes up by 2 to 3 bits per minute. So this also has a similar result, but again it's compared to the other GLP-1 receptor agonists. So we do not know the exact significance. So this is one finding where it does similarly to rest of the GLP-1 analogs. Blood pressure actually goes down. So this is something which is beneficial. So that is both the systolic as well as diastolic. Primarily the systolic goes down, and it did not increase the risk of MACE in the SURPASS 1 to 5 trials, but we'll be having the dedicated CV outcome trial data most probably this year. So finally, to conclude, so this is a new molecule which has multiple unique aspects. So this is a molecule which manages to uh, help you avoid whatever you should not be eating. So it causes weight loss. One of the most potent weight lowering agent till now that has been approved. One of the most potent HbA1c lowering agent that has till now that has been approved, and it has this tolerability which has remained a challenge for many of our patients who are already on GLP-1 analogs, primarily gastric tolerability, GI side effects. So that is not that big a challenge. The dropout rate in most of the surmount and surpass trial, what we see is like 4 to 6%. So that is not that high. So that is something which we look forward to, because otherwise the GI side effects play a major role, as acts as a major hindrance for chronic use of this, long term use of this molecule. And obviously it has a positive effect on blood pressure, it has a positive effect on lipid. Some of the effects which might have apparently might look that okay, this is a molecule which is increasing glucagon, or this is a molecule that is promoting lipogenesis, so the glucagon, we have data that there is no such issues. For fat accumulation, it's the good fat, the white adipose tissue, non-dysfunctional fat which is getting accumulated. And ultimately we are expecting that we'll have a very robust result when the CV outcome dedicated trial data comes up. So it has multiple benefits. We are all looking forward to this molecule. I now thank you everyone for joining this session and patient listening. I hand it over back to Dr. Wazir.